Next, we are going to have a key opinion leader moderated conversation led by Dr. Ken Culver. He is our ALK Positive Director of Research and Clinical Trials. He has been an amazing and incredible addition to our organization for almost 3 years. I think 3 years in September. Is that right, Ken? And he has exhibited such incredible passion and commitment for our mission and such a great amount of tolerance for our questionable senses of humor. So we're really, really, really happy to have him join us. And we also have a great panel, which includes Dr. Alice Shah, Dr. Jessica Lin, Dr. Angel Chin, Dr. Ross Kamaj, and Dr. Mark Awad. If y'all would like to come up, we welcome the conversation. Thank you.
Wow. Thank you again, Jessica. It's so wonderful how, in fact, I'm going to sit down there because I need to see the screen. Thanks, Angel. Sorry, my eyes aren't as young as they used to be. So it's a pleasure to be here. In fact, Jessica just highlighted so many of the key points that we're going to talk about as a group. We also have another panel tomorrow. We're going to talk more about these issues in a context of clinical trials because they're the fundamental part of making all this happen. And then this afternoon, I think around 1 o'clock, we're going to go again address some of these key issues on how we, ALK Positive, are investing in making research in those areas become ALK specific. Because I'm looking forward to the day when instead of us using EGFR as the example, we're using ALK as the example. And that we want to bring to fruition through the investment of the dollars that are donated to make sure we're doing the smart trials that are going to advance us towards that cure, to the cure. So, let's just get started here. Okay, so with this group, our agenda is twofold. We're going to talk about decisions in the first line, not about what drug you should start on. Jessica covered that beautiful in her keynote speech. But there are things that still need to be done and considered while you're on the first line, and the local consolidative therapy is one example from Jessica's presentation. The second thing we want to talk a little more about is something, again, that Jessica highlighted, is at progression, how do our experts think about the next treatment for you, whether you have mutations in the ALK gene or not? And it's so beautiful that the keynote has laid the foundation for what we want to speak about today. I want to go over 2 slides, sort of general slides that will sort of frame our discussion. And I want to use it in a case format. So what we're looking, I can't even, let me try my reading glasses. It's kind of embarrassing. I'm over 40. Okay. So this is a 48-year-old patient who presents with respiratory symptoms, and they get to a good oncologist. The oncologist does the proper workup. They do the ALK testing right up front, and they're now put on a TKI. That all sounds great. That's what we want to have happening most of the time, all the time, for every patient with lung cancer. All right. And then these are the 3 Kaplan-Meier plots for the 3 most commonly used TKIs, alectinib on the left, brigatinib in the middle, and lorlatinib on the right. And one of the things, whenever you're in a talk by one of our experts, they're going to show you these Kaplan-Meier plots. And these Kaplan-Meier plots are always the same. On the x-axis, it's always time. But the time frames aren't the same. So if you look, you'll see that they're not identical. So you have to always look at that and say, oh, this is only 6 months, or this is 3 years, or this is 5 years, because they have different meaning. The y-axis is always going to be percent. And so everybody starts at 100%. Everybody's alive in the beginning. And then with time, the graph goes down when people either have progression or of their cancer, or whether they've died, depending on what the purpose is. These are progression-free survival, and what that means is the graph goes down every time a patient has a recurrent, their tumor starts to grow again, they have a new tumor, or they die for any reason. And so that's what progression-free survival is. And why you're asking, this is one of the most important measures that we use in assessing the effectiveness of drugs. But I wanted to point out here, as Jessica pointed out, the first 2 years for all 3 of these drugs shows a drop-off. And between 30 and 40% of patients are going to progress in the first 2 years on these drugs. And one of the questions we're going to get to with the group is, how do we know who those patients are? Can we know? What do we need to do to know? And I think it's so important to know that we've got really good drugs, but not everybody gets out to the 8, 10, 12 years. Then it's about safety. And this is a really complicated table. And Alice Shaw gave me some advice. She said, Ken, you need to use some way to kind of show what is common and what is different. So if you just look at the pattern and you see the gold rows, those are side effects that are generally common across the 3 TKIs. And the ones that are in white are ones that are more unique to 1 or 2 of them. So my conclusion from this is the toxicity profiles have things that are common, but there are also distinct differences. And our physicians will obviously take that into consideration in how they prescribe and who they prescribe different drugs to. So with that in mind, we're going to get to the most important part of this presentation, which is trying to get the slides to go forward. There we go. We meet as a patient caregiver group every Tuesday at 1 o'clock. And we talk about how can we get more research for ALK positive. And this group is called the RAC, the Research Acceleration Committee. It was one of the committees established by Colin when he was leading the medical committee. And we got together and we said, what are the key questions that we want to know from this group? And so these are the 8 that we came up with. They overlap nicely with what Jessica just spoke about. And in fact, Jessica told me in our preparation call this week, she said, I'm so happy with these questions because these are the questions that I get asked so often in the clinic. So we're going to start, we don't have to go in a specific order, but let's just start with question 1 and go from there. So Alice, you happen to be sitting next to me. What do you think about, what do we know about who are going to be the short or long-term responders, and what can we do to better understand that?
Oh, well, thanks, Ken, and thanks to all of you for coming to this amazing summit and for having us here. Yeah, this is a tough question, and I think Jessica alluded to this as well in her talk, that when we first meet a patient with newly diagnosed ALK-positive lung cancer, we generally can't predict who's going to do really well, for 5, 10 plus years, or who may actually have one of the earlier relapses. But there are a couple clues that sometimes might suggest that a patient may not do as well. I think sometimes when we see patients who have really, really extensive disease at diagnosis, extensive metastatic burden of disease, then I worry that they may have sort of just more heterogeneity, so different types of cancer cells. They're all ALK positive, of course, but they have a whole lot of different ALK positive cancers, and that could make them potentially have maybe slightly shorter responses. But the other thing we look at sometimes are the molecular results from the NGS, so your next generation sequencing. We know that there are some markers that sometimes associate with shorter responses as well. So many of you know about the P53 tumor suppressor gene, so P53 mutations in the literature. It's a bit mixed, but there is a suggestion that those patients may have slightly worse outcomes. The other really interesting marker that I also look at is the type of ALK rearrangement. So you may know that there are many different ALK fusions that can actually cause lung cancer. EML4 ALK is the most common ALK rearrangement, and even with EML4 ALK, there are different what we call variants. So different portions of EML4 can be connected to ALK. And the most common EML4 ALK variants are variant 1 and variant 3. So again, you may see this on some of your next generation sequencing reports. And it does seem, we do have data from clinical trials suggesting that the shorter variant 3 may benefit a little bit less than the longer variant, variant 1, to first-line, second-generation drugs like alectinib or brigatinib. Although with frontline lorlatinib, we actually don't really see any difference based on variant. And so I do look at that data, and especially when I'm seeing a new patient and we're deciding on our first TKI, and we're talking about second generation, or now, of course, the CROWN data really suggesting we should be using lorlatinib. And when I see a variant 3, I for sure am thinking we really need to push for lorlatinib in that particular setting. But curious what others on the panel think.
I think the data are coming together to increasingly support that these molecular variations, like the specific ALK variant that you have, like Alice was saying, and the p53 mutation status, in fact, do associate with time on ALK inhibitor before you experience disease progression. Across lung cancers, we're also finding that generally in people that have enough of a cancer burden at start to be shedding a lot of cancer DNA into the bloodstream, that may associate also with shorter time on therapies. However, I think the difficult part is that none of these right now are perfect biomarkers, and certainly findings of p53 mutation versus not, which ALK variant you have, it's not really dramatically changing the treatment choice today when we're meeting a patient for the first time. But as Alice was alluding to, the hope is that in the future, perhaps we may have a composite, for example, of variables that we can look at together that may predict better who's at higher risk versus not, so that hopefully we can incorporate it into our treatment decision making each step of the way. That's the endpoint that we're working towards.
Is this one working? Oh, hello. So I agree with all of that. I think Jessica said it well. None of these are perfect biomarkers. And I think, you know, for those who are recently diagnosed and they've got their p53 mutant status and they're going, oh no, this is terrible, 50% of the people in this room are going to be p53 mutant, including some of the 10-year survivors out here. Colin, can I call you out? How many years have you been going?
9 years at the moment.
And you're p53 mutant, right?
Yeah,
so these are associated with worse outcomes, but they are by no means a guarantee of bad outcomes. And so we're just scratching the surface now. When we find things associated with worse prognosis at the moment, and we'll go on to talk about this, you know, we can talk about different consolidation approaches with kind of like dumbed down things like chemotherapy and radiation. What we're really hoping for, and Jessica mentioned this in the talk, is to find something that says, you've got a worse prognosis because of X, and then we can personalize it to that, but we're not there yet.
Okay. Ross, could you continue on about point number 2? I know a lot of our patients have mentioned how you're using different markers to try to guide surveillance.
Yeah, so you can do various blood-based markers that range from, you know, Guardant blood-based tests looking for specific molecular changes in the blood. There's something called Signatera, which is not really profiling what's driving the cancer, but just telling you if the cancer's there. Or there's old-fashioned serum tumor markers like CEA, CA125. I personally do not change treatment on the basis of those markers, which I track at the same time as the scans. I simply use them to tell me, if I'm using CT scans, if the CT is missing something. So if the markers are going up, you know, if it's elevated and then you recheck it a few weeks later and it's still going up, all it tells me is the CT is missing something, and then I do a PET scan. Because the function of surveillance in my book isn't just to tell me when the cat is completely out of the bag and the treatment's not working, it's to find an early stage of progression, when there's just one spot growing, that I can zap with radiotherapy and stay on the drug. I was having breakfast with a friend from Israel this morning, and he gets PET scans every time, so there's no, or his wife does, and so there's no advantage there of those markers. But for those of us in the USA, where we're often doing CT scans, they're just an additional warning system to say the CT scan might be using it.
I think the trouble with some of the biomarkers is, I think, as Ross said, we're just kind of scratching the surface and trying to understand how to use them to inform our treatment decision. And a lot of these biomarkers, whether it's the P53, ctDNA positivity, whatever you will, are more prognostic, right? If we see it, we understand that patients could, not will, but could have worse outcomes. But we haven't yet reached a point where we could use that biomarker to change our treatment decision, and that leads to a better outcome. Right? I think that's the big gap that we have, and that's what we really need to do to advance, biomarker space forward in ALK and other lung cancers.
I can make a quick comment, because you mentioned on your question, do you follow PK? So that's referring to sort of the exposure, how much drug actually is in your bloodstream. And in clinical trials, we actually track that level of drug in your system. It's really important in terms of guiding drug development. But once drugs get commercially approved, it's actually very hard to actually track, determine what we call PK levels, drug levels in your blood. And actually, so many of my patients have asked about this, especially with lorlatinib, if there's a way we can check drug levels, because oftentimes, as we'll talk about, there are side effects with lorlatinib, and we really know that they'll get better with dose reduction, but everyone, including us, the patients, family members, us, we all feel nervous about bringing down the dose. And so if we had some way to guide us around drug levels, that would be super helpful. So I wanted to highlight that because we've got our industry partners here, and I would love to have wider availability of tracking drug levels for our patients.
I think, and certainly if anyone in the audience has questions, because I know a lot of people are newly diagnosed, some of these terms may not be as familiar, but I'm always impressed with new patients, how savvy and quick our patients are to learn about the field. So, in terms of circulating tumor DNA or ctDNA, again, just to emphasize, this is tracking how much ALK DNA we can measure in the blood, and that's not something that I currently routinely check as surveillance, meaning when patients are coming in for every visit, I don't send the circulating tumor DNA, but I think as Jessica nicely highlighted, and as a lot of people have mentioned, this is really important if we need to make a treatment change. So at the time of what we call acquired resistance, when the cancer appears to be growing again, that's when it's especially important to try to send ctDNA or get a repeat biopsy to understand what is changing about the cancer, and can we use that to tailor or inform the subsequent treatment decision. So it's not something I send at every visit, but it's really important to send at the time of a need to make a treatment decision change.
Similarly to Mark, I am not routinely sending blood biomarkers today for patients on treatment. I am monitoring by scans because ultimately that is what will determine treatment choices. However, we're all hopeful for a day when we will have better blood-based biomarkers that may complement scan findings. We're just not there yet. There are certain cancers, as you may have, family or friends who have other cancers like prostate cancer or pancreatic cancer, where there are very reliable, more reliable blood markers that we can track. But in lung cancer, we're just not there yet.
So I'm really curious about question number 3. When you see a patient and you're thinking through the possibilities for what to start them on, are you thinking through their entire treatment plan? Or are you you're just saying, well, I'm going to put them on the lorlatinib, they're going to do well for a while, and I'll think about what to do next later? I'm not trying to minimize the importance of it, but I'm just curious. I think our patients are also wondering that. That's why it's on the list. Mark?
Yeah, I think we're always thinking ahead for our patients. At every given visit, we're always thinking, what am I going to discuss with the patient, depending on, what the scan shows. So we, sometimes offer patients same-day scans, especially if they're coming from far away, and we have to plan ahead and think, if the scan shows something new, what are we going to discuss as a next step? And that is true, when we're meeting patients for the first time, selecting first-line therapy. But I also say, what I talk to you today will certainly be different about what we might talk about a year from now or 5 years from now. So, we can talk in general about first-line therapy if we're starting, say, for lorlatinib, for example. we might say, generally speaking, what I might do if we need to make a change from lorlatinib to something else. But what's really exciting is that the standards of care keep changing every year for ALK-positive lung cancer, so that how I manage a patient today who needs to switch from first-line therapy to second-line therapy most likely will be different several years from now. So I think, we are moving towards using lorlatinib more in the first-line setting based on the exciting long-term data that we've seen from CROWN. Some patients, again, can't stay on lorlatinib because of side effects for certain reasons, and then we have to switch to something else. And fortunately, we have a number of very potent active ALK inhibitors that we can choose from if somebody needs to make a switch.
Yeah, I was just going to add, Mark, it's such a good point that the field has been evolving so quickly, right, over the since the discovery of ALK in 2007 to now. About 18 years or so, we have 6 approved ALK inhibitors. We're out to 4th generation. And I was thinking back as you were talking, Mark, to some of the patients you and I may even have seen together in the very beginning when they were just starting crizotinib, for example. And yeah, we would think ahead, but there's no way we could have predicted that we would then have 2nd, 3rd, 4th generation and other treatments. So it is hard to plan it out precisely. So I think, just like Mark said, often we're thinking a little bit broadly, but the field is going to continue to evolve. The other thing I would say right now, Ken, that's really hard about mapping out exactly what to do after first-line lorlatinib is, as Jessica pointed out, we are still in the early days of really understanding what drives resistance to first-line lorlatinib. And so because of that, it is hard to know right this moment exactly what we might do if someone were to develop resistance to first-line lorlatinib. But that is why it's even more critical then for anyone who is on first-line lorlatinib now or in the future, if there were to be signs of resistance, to undergo the liquid biopsies that we've talked about, I would say also the tumor biopsies, and really try and add to sort of our knowledge, our understanding of what's driving resistance to first-line lorlatinib, because that will absolutely help us develop better, more tailored therapies after lorlatinib.
I think it's impossible to map out your entire treatment plan in advance. What I have learned over the years is that it is helpful to have certain guideposts for things to consider when you're finding out that cancer may be changing in some area of your body. And so we can talk about some of those guideposts now, right? Let's say there's cancer getting worse. You learn that on a CT scan, there's cancer getting worse. I think all of our faculty members' uniform practice is to make sure that at the time of any cancer change, we like to make sure that the whole body is surveyed. So making sure that even if the CT scan showed a finding, making sure that brain imaging is done at that time, right? Brain MRI. So that's one thing. We always like to understand what's the pace of change in the cancer and where is cancer changing? What's the pattern of cancer change that can guide our discussions about the next treatment options? And then secondly, as I alluded to in my talk, we do like to think about rebiopsies, whether that's in the form of biopsying the growing tumor or blood biopsy. We're going to return to this topic with the second case, but that's another guidepost to think about if that time comes where you're having to think about treatment change.
Let me try a different take on Ken's question. So I think when you get, we're supposed key opinion leaders, but we don't like to label ourselves that. But anyway, us on the panel here, we're all sort of saying you should be starting on lorlatinib if you're brand new diagnosed. If you're already on something and doing great, as Jessica says, don't worry. Yet that data came out more than a year ago, and if you look at new prescriptions across the USA, they're not all for lorlatinib. There's still a lot of people prescribing alectinib and brigatinib. And sometimes when you speak to the community oncologist, and remember 80% of people are treated by community oncologists, their argument is, well, I'll start them on that, and then I know what I'm going to do next. I'll stick them on lorlatinib later line. And I am very unsympathetic to that strategy, because the goal is to get the person on the right treatment, not just to give the oncologist an easy conversation of progression. So I think we have to firmly push back that it's not like A is always followed by B, because then I don't have to worry about the decision-making process. And I think you guys can correct me if I'm wrong, but the first-line prescribing for lorlatinib is still only, 20% nationally?
We have to ask Pfizer.
I mean, we didn't suddenly see that data and it went to 100% first line.
I think that from a patient's perspective, it's nice to know that their oncologist does have a backup plan, right? As we all said, we don't know who are the patients that are going to progress quickly in the first 6, 12, 18 months. So we always hope for the best, but I feel like it's also my job to prepare for the worst, right? So what if the next scan they get, something unexpected is there? So while I agree we can't map out the exact details that we're going to do with each step, having a next plan in mind, it's helpful, whether we're going to refer them for radiation, whether we're going to refer them for a clinical trial, whether we might even recommend chemotherapy. I think it's important for patients to understand that there are other options. So I think a lot of times, especially when I see second opinions, patients have this feeling that if they don't do well on a TKI, that's it, that there are no other options, and this is it for the cancer. And I think as Jessica really nicely highlighted in her talk, there are a lot of things that people are working on, new novel biomarkers, new novel drugs. So there's importance for that hope beyond just the TKIs.
And beyond the time when you're having to select the first drug that you're going to be on, I think these are discussions that can happen periodically during your treatment course, even when you're doing well. Sometimes when the scans are looking good and you're discussing your current symptoms or side effects that you may be experiencing, those minutes of the visit go by really fast, right? But it's helpful to make a point to check in with the doctor every now and then, whether that's every few months, right? Making a point of taking a step back and saying, let's focus the next few minutes on where the field is right now and where we might go as a next step based on the current options. And if the doctor is a general oncologist, and then it may be helpful to get a second opinion at that point with people that are at the forefront of the field because they're focusing on ALK positive lung cancer or have the luxury of time to focus on a small part of lung cancer, right? So these are things you can think about even when you're doing well on treatment, even if the treatment has already been initiated.
That's beautiful, because we want everybody to be proactive and be ahead of the curve, right? So that's really nice. So if I'm hearing this right, there's no standard of care after first-line nilotinib. So if that's the case, should everybody who progresses on first-line nilotinib get a second opinion? Because how do you know? I mean, Raj, you said 80% are out in the community, but if there's no standard, then how is a general oncologist going to make a decision on what to do next?
There is, I think there are two sides to that question. There is a, so to say, standard of care in that the standard therapy off of clinical trial would be chemotherapy. I always encourage second opinions myself. However, I hesitate to answer yes to that specific question just because we realize that getting a second opinion itself is not a possible option for everyone. Right? It's not going to be possible for everyone to travel to get a second opinion. It can be costly, it can be hard time-wise. You may not be feeling well. So I think because of that, it's really important, the efforts that the ALK Positive group is making with the websites, with possible clinical trial options, and all the different ALK talks and webinars, I think are really helpful. If you have the luxury of being able to get a second opinion, that's why I think it's important to consider it even when you're doing well, because if cancer's progressing, not always, sometimes you may be not feeling well enough to travel, right? So it's good to establish that connection. And if you are able to get a second opinion, great. But if you're not, there are friends and community around to help guide the oncologist. We often do direct oncologist to oncologist phone calls, right? And communication to help guide them from afar.
Just maybe wanted to emphasize one thing, or maybe reiterate one thing. I mean, progression on first-line lorlatinib comes in many different flavors, and so I do think we have to be a bit careful. It doesn't always mean that you immediately need a switch of your systemic therapy, so you immediately need a new therapy or one added to lorlatinib. As we talked about, you could have a single site of progression, what we call oligoprogression, which would be managed quite differently, right? You might have a small change in a spot in the brain, again, which we would manage quite differently. And so I do just want to make that point that it is pretty complicated. So as we're all saying, if your oncologist is not as certain about what to do, yes, reaching out would be great. Second opinion, great if possible, and then other resources, especially through this community.
Fantastic. What great information. Let's move to question number 4. We haven't really touched too much on safety. The question is written, when is the safety profile more important than efficacy when choosing a TKI? And that can be in any line of therapy. Mark?
Right. I think, of course, safety is critically important, and we can divide safety into the more sort of high-risk types of side effects, and then the more sort of chronic, nuisance, annoying side effects, which I think are both really important. There are certain side effects that mandate that we hold drug, stop drug, or adjust the dose. There are others that we rely on patients to really tell us how much it's affecting their quality of life. There are certain things that we can see and measure. For example, some of the feared but serious side effects of any tyrosine kinase inhibitor include spikes in the liver tests, what we call hepatitis. And sometimes they're very mild and we can track and watch them. Other times the liver tests really shoot up. Other things include lung inflammation, which is called pneumonitis. And that can be quite scary because it can trigger shortness of breath and respiratory symptoms. So there are certain things that we see or that we can measure or keep track of that will tell us that we need to make adjustments in the dose or give a pause on the drug until those side effects resolve. And then there are the other side effects that can still be very meaningful and important, such as weight gain, some neurocognitive side effects. Sometimes some lab values can become abnormal, like the cholesterol or triglycerides with lorlatinib. So I think what's tricky, similar to that first question where there's a lot of variability in terms of outcomes or response or duration of response, there's also a lot of variability in terms of side effects and tolerability of drugs. And that's also something we really can't predict very well. So we can take a few patients and they can have really variable side effects where one person has liver abnormalities, another has a lot of what we call sort of neuropsychiatric side effects to lorlatinib, and others have zero side effects and can tolerate really high doses quite well. So I think this is also really important. At the outset, I think there's not a lot of patients that I meet up front that I say, I wouldn't prescribe lorlatinib because of certain, concerns of, I know you're going to have these side effects. So I think we generally try to pick our most favorable or strongest TKI and then monitor very closely. So we usually, when starting a new therapy, see patients back, maybe 2 weeks into treatment, 4 weeks into treatment, and then, hopefully as patients are doing well, we can start to space out the visits. But, some side effects can come early, some can come late, some can kind of gradually build up over time. So it's really important to continue to inform your oncologist and your treating team about side effects that are bothersome and interfering with your quality of life. I do know, I've heard from some patients that they are a little bit hesitant to share how they're feeling on therapy out of a maybe concern or fear that their doctor might want to hold the dose or reduce the dose. But it's really important that we work together to find these therapies that can be especially well tolerated and can be used for long durations of periods of time, because we want our patients to be on these treatments for years, and we want to maintain really excellent quality of life for that duration of time that they're on treatment. So I think talking about safety, talking about side effects, because there are often things that we can talk about in terms of making a treatment more tolerable. So I think these conversations are especially important.
So I guess maybe just with the patients I've more recently seen, I guess I will take a different approach. I agree that I think for a patient who's appropriate for lorlatinib, that's what we should recommend, but I also hesitate to say everybody should be challenged with lorlatinib. And I'll give a great example. I recently saw a patient who is in their late 80s, very, very limited in what they can do on oxygen. It actually came in with a stage 2 ALK positive lung cancer, but can't get radiation, can't get surgery. And there was just no way that I thought he would be able to tolerate lorlatinib. And we actually went back and forth about whether or not they even would want to try something like alectinib, and they did. And for the last 2 years, they've been pretty well. Now, I haven't improved their functional status, but I certainly not worsened it. So I think that the patient that sits in front of you, their comorbidities, their goals, how they're doing is going to be super important. Absolutely, I think as we learn more about lorlatinib, and it's important that there are lots of different ways to manage the side effects. Do not be scared to tell your oncologist about them. Dose reduction doesn't mean it's a bad thing. We need to make this drug tolerable, as ultimately we want you to be on it for as long as possible. But I strongly feel that there are definitely patients that I would not challenge with lorlatinib.
Yeah, I would agree with both Angel and Mark, actually. I mean, and just to your question, I mean, I think safety is critically important. I mean, these are drugs that we hope that you're on for years, and so we want you to feel well and have great quality of life. So we are always thinking about safety. I mean, to Angel's point, I mean, there are patients who I do worry about prescribing lorlatinib. As you mentioned, older patients, especially if they have a lot of other medical issues. They can really struggle even with dose-reduced lorlatinib. I would say patients who have baseline significant psychiatric disease that's not well controlled, those are also patients who I've seen really can struggle with lorlatinib. And then just to lorlatinib for the sort of general population, I would say the standard dose of 100 milligrams is quite challenging for a lot of patients. So I know most patients are prescribed 100 milligrams to start. I personally actually usually start lower at 75 milligrams, but it's perfectly fine to start at 100 milligrams. And I would point out that we looked in the CROWN trial at patients. Of course, all the patients who enrolled on CROWN and received lorlatinib received the standard 100 milligram dose. But of course, a fraction of patients did require dose reduction because lorlatinib can have side effects. And we looked at that subset of patients who required a dose reduction in the first 4 months, and their outcomes in terms of how well the drug worked in both the body and the brain were exactly the same as the patients who were maintained at 100 milligrams. So I am very comfortable with dose reducing. Lorlatinib is a very, very potent drug, and we have evidence that it's very active at the lower doses.
I like to think of question number 4 as a Ken's trick question, because I don't think of it ever as safety versus efficacy. Actually, it's part and parcel of one package. Safety and efficacy together, couched in your goals in terms of what's important to your life. And so for first-line treatment as well as for subsequent treatments, the doctors will always be talking to you about, look, like this is what we know about effectiveness. These are potential side effects. Based on your own known conditions and your prior history, these are the side effects I might worry more about, and then go from there in terms of selecting the treatment. So I don't think of it as one versus the other ever. It's always a package of one whole discussion.
Oh, you caught me on my trick. There may be another one, so keep an eye. Ross, number 5. When do you decide, and what's the optimal time for consolidation?
Well, this is a work in progress. So Jessica mentioned local consolidation therapy, most commonly with radiation at the time of maximal response. And, is that something, I think it's something that you should consider and have a discussion with your oncologist with, but I don't think it's mandated for everybody. The things that we don't know are, let's say you have an amazing response and everything shuts off on your PET scan. Do you still aim at the residual sites of disease, knowing that because they're below the limit of detection of the PET scan, doesn't mean there aren't any cancer cells there? What if there's many, many sites of disease that fit that description? Do you just treat some of them versus others? We don't really know, but it's an evolving field. Certainly if you started off with 3 sites of disease and there's residual activity on your PET scan, it's an easy peasy decision. But exactly how far we should push it, we don't know. The other thing, which Jessica didn't mention, is building from the EGFR field, should we consolidate with chemotherapy? We know that a subgroup of people, as Angel hinted at, maybe as much as 30% with ALK will have amazing responses to pemetrexed-based therapy. Should we push the envelope if somebody's had a suboptimal response, give them 4 cycles of carboplatin and pemetrexed added into their TKI, and then give radiation? These are all ideas, hypotheses. We don't know. It's just a conversation that you have, and again, it depends on your appetite for more toxicity, for an unknown but theoretical benefit.
I agree wholeheartedly. I have so much to say on this topic. We don't have enough time. Scientifically, there's so much unknown about residual disease and persister cell biology, and that is one of the big aims of the BTC Lung Team Lab Collaborative. When you think about precision oncology, this idea of precision medicine, the whole idea, the definition, is delivering the right intervention, the right treatment, at the right time to the right people, right? And on none of those three aspects do we know the answer when it comes to intervening on residual disease. We don't know what the right intervention is. Today, at the practical level, we're limited to what we can deliver in the clinic, which in many ways is things like radiation or surgery or chemotherapy. But in the future, hopefully we'll have more tools in hand in terms of the right time. We don't know what the right time is. Is it on that first scan at 6 weeks or 3 months? When you are having the biggest cancer response, but there may still be some way to go, but before those persister cells have had more opportunity to simmer along? Is it at 9 months when your cancer shrinkage has reached its maximal state, so you have the smallest burden of cancer before cancer starts growing again? Biologically, we don't know what that right time is. Nobody has looked at this question systematically, and part of that is that it's really challenging to look at. And then who are the right people? Should those additional interventions be given to everyone? Anytime we add an additional intervention or therapy, we worry about possible toxicities, right? Nothing we give medically is without possible risks. So it's always about balancing the potential benefit with the potential risk. And those three pieces, the right tool, the right intervention, at the right time to the right people, when it comes to consolidating and attacking that residual disease, those are questions that we really do have to answer in the hopefully in the near future.
Thank you, Jessica. So, Kirk, what time are we supposed to finish?
Ken, I told you we're not going to have enough time.
Yeah, I think we have another 15 minutes. Don't we? Yeah, good, because I thought there was going to be a timer up here, Nancy. Sorry, I was all right, so we have 3 more questions in 15 minutes. So I have to show Jessica's wrong now.
No, but there's a whole second case, remember? That we're not
I did forget those, didn't I? This is so good, I completely forgot about those. Okay. Well, then looking at those last 3, any comments on any of those from anyone?
I think I'd like to make a comment about the dosing. So I think, we've talked a lot about dosing, especially with lorlatinib, but all the other TKIs. And I think it's critically important to understand that currently the way that clinical trials are designed in terms of how dose is determined is often we push to the maximally tolerated dose, right? So at what toxicity level can patients truly tolerate before a significant portion feel unwell? And that's the dose we choose. So we often choose a dose that probably supersedes the maximally effective dose. And so this is why there's now been a push, you'll see in clinical trials, that a lot of times they'll actually design drugs with different doses because we're trying to actually find what's truly the optimal dose, which is not always the highest dose, right? So more is not always better. And so I think that's really important to understand because, as has been pointed out, patients have this hesitance, or even oncologists have this hesitance to reduce dose because we're so fixated that this is the approved dose, it must be the best. And that is not how currently the drug development trials are based on. So I think it's absolutely okay to talk about dose reduction as an excellent strategy to manage the side effects and to keep you on the drug for as long as it's helping.
Yeah, on that point, this is a kind of truism in drug development, that dose is not exposure. And what I mean by that is we can take 100 people in the room, give them all the same size pill, but the levels in their blood might be very different. And maybe the side effects are telling you about what the levels in your blood are, and that's more important than the size of the pill you put in your mouth.
Thank you. All right, we're going to go, thanks to Jessica's help here, we're going to move on to 2 last questions. We're back to our 48-year-old and was put on a TKI, but unfortunately, a couple of years later, the individual has a recurrence, and there's a biopsy and tissue testing, and they find that there are now mutations in the ALK gene in addition to the original rearrangement. So the question to the panel is, and Jessica addressed this a little bit, what do you do now? I have pasted it on the right as a graph from a Nuvalent publication that sort of, for those of you that aren't familiar with these heat maps, it basically, it's trying to show you which TKIs are active on which compound mutations. I don't know, do you use those? How do you decide now? Jessica, you asked for this.
So whether we use those heat maps or not is a loaded question, because there are pros and cons. I'll be completely transparent with you. I do refer to those heat maps because you've got to start somewhere. So what those heat maps are is testing from the laboratory using ALK positive lung cancer models and looking at how effective the drugs are in the cell line, for example, in the dish at inhibiting the growth of those ALK positive lung cancer cells. And so it's looking at the level of effectiveness there. We all know that these data are not perfect. In fact, when you look at cell line data, those will not always translate perfectly to what we see in patients with cancer. So that is a big caveat. However, that said, we've learned over the years with ALK positive lung cancer that when we try to use the information gleaned from laboratory research, heat maps like this, and choose the best ALK inhibitor to use for patients as next option, often the clinical activity that we've seen did correlate nicely with the information gained from lab experiments. And so it is helpful in my mind to have those heat maps in hand and to refer to them. It's not going to be the only data we look at, understanding the imperfections, but it becomes a helpful piece of the decision-making process.
Yeah, I would just add that finding an ALK mutation in a biopsy taken after someone has developed progression is usually regarded as a pretty positive finding, because for us, that suggests that the cancer remains dependent on ALK. So the cancer has tried to mutate around the inhibitor that you're currently on, and still could respond then to another ALK inhibitor that is able to target that mutation. So if we find an ALK mutation, we often are quite excited about that, and we will consider sort of the next generation, more potent, more pan-inhibitory ALK inhibitor. So if this were a patient, for example, on alectinib, and we identified the most common resistance mutation that emerges, which is G1202R, we know that actually lorlatinib, as well as Nuvalent, the MVL655, are very active against that mutation. And so we know that we would have other ALK-targeted therapies as a next-line option.
Yeah, just one point in terms of academic sleight of hand is that the color coding can vary between presentations. So I can set it by a particular concentration. If it's below this, I color it one color. If it's above this, I color it another color. But what you really want to know is the concentration that you would achieve with a certain size pill in a person to determine if red really is a no-go. Mm-hmm. And so the best ways that these ones are color-coded is when they factor in clinical exposure, and they don't always do that. Sometimes it's, there's a famous presentation where they set the cut point between red and orange at kind of like 50 nanomolar, and in one slide it's like 51 nanomolar, and another is like 49 nanomolar, and one is like a no-go, and the other is like, yes, you can do it. And obviously that's nonsense.
Once you start talking about ALK mutations and what next ALK inhibitor may be a good option, that does start getting very granular, where second opinions may become very helpful.
Great. We're going to go on. We're coming back to this 48-year-old patient again who's been on a TKI for a few years, and now the recurrence is different. The recurrence has no mutations, the same exact NGS profile from the very beginning. And now what do you do? And I know there are a number of you here who've been in that situation where you're trying to figure out, okay, what's driving my cancer to grow? And if you look on the slide and you look in the lower left-hand corner, our scientific advisory board met at ASCO at the end of May, and we spoke about, well, what should be the standard evaluation of a tumor when someone recurs on a TKI. And these four different things there we're going to talk a little bit about, because as Jessica alluded to in her keynote, that we have now other drugs available, HER2 being one of the examples she gave. And so if you don't look for it, then you don't know it. So this has been one of my big concerns in the education aspects of what we do as ALK Positive, is for you to know at recurrence, what should your doctor be testing in your tumor, so that you have all the options available. So if you could, so I'm going to start with Ross, because Ross was the last one I spoke to about this. Ross, you're using all of these modality, including HER2 amplification. Is this in everybody at recurrence?
So so obviously you have to remember that sometimes tissue is limited. So in an ideal world, if you got a tissue biopsy, you would do next generation sequencing that's based on both a DNA and an RNA extraction. So you're looking not just for ALK, but those second drivers that Jessica mentioned. We've also got those protein biomarkers, HER2 and MET, that we'd be looking for. MTAP, Alice mentioned too. The other thing to point out is sometimes people are checking the box by doing blood-based testing, which if you find an answer is great, but if you don't, that doesn't mean there's no mechanism. So you can send off the blood, but if it doesn't give you the answer, you should be doing a tissue-based approach.
And based on that, so if you go, a second, Mark. So if you're, you go to your doctor's office and you say, I'd like to have these tests done, and they say, sorry, you can't have a biopsy, do you go get a second opinion?
That's a loaded question, right?
Well, it's just,
because honestly, the oncologist doesn't determine what you can biopsy. It's usually the interventional radiologist.
Yeah.
But yeah, I can give you an example where somewhere out there's a remote second opinion patient who has an adrenal lesion which is progressing. And they were told that they couldn't get a needle biopsy because it would go through various other important structures. And I said, well, you could actually have a laparoscopic adrenalectomy, where they push these things out of the way. And their hospital doesn't do those. So there it was kind of like, well, there is an option if you go somewhere else.
And that's what I meant, because experience and expertise or technologies vary from place to place. So it's not necessarily a knock against the oncologists, it's just availability.
There are also probably locations that are much more tricky, right, to biopsy. So like if you have brain progression, right, I think we all have much less stomach to try to do a brain biopsy, so that may not always be feasible. If you have a lymph node or a nodule, that's really hard to navigate, even with the fancy cameras and toys that they have now. That can be a challenge, right? So I think the point is that if tissue is possible and safe, that should be done, because as Jessica alluded to, these new biomarkers, we can't detect that on ctDNA, and they are tissue-based biomarkers.
I just want to add 2 points. One is that the IHC studies to look at the protein biomarkers that we've talked about, MET and HER2, and plus minus MTAP, if you're at center that does that. It doesn't have to be done with a new biopsy. So if somebody's already had a biopsy done, for example, at the time of diagnosis of lung cancer, and there's leftover sample available, they can try to use that sample to do these additional IHC studies if there's enough. So that's one consideration, that you don't have to be going to the doctor and asking, oh, I want to get a new biopsy done to get these tests accomplished. The second point I wanted to make is that not always is it the best, smartest strategy to get the biopsy done and wait for the result. So often, things like NGS from a biopsy can take some weeks to come back, depending on where you're located, and depending on how you're feeling, what the pace and the pattern of cancer progression is. actually it may be more prudent to go ahead and start on a treatment, whether that's chemotherapy or something else, to calm things down and to slow things down while the biopsy is planned or pending. Then it's very individualized. So we don't want you to walk away with the impression that, oh, if cancer is progressing, I must get the biopsy done and have that result come back and sit tight for the result before embarking on a treatment course. That may not be the right way to go.
Can I just pick up on one? Oh, I'm sorry, Alice, go ahead. So, whilst I agree with you in principle that MET and HER2 and MTAP could be present at baseline, particularly the MET, because it can be a mechanism of acquired resistance, even if it was negative, can become positive.
I totally agree, yes. And that's an area where there's a lot of ongoing investigation. It is dynamic. So sometimes your cancer may overexpress some of these proteins at initial diagnosis. Perhaps it's not as overexpressed at the time of progression. Perhaps at diagnosis it wasn't as overexpressed, but it was induced a little bit after ALK inhibitor therapy. So always, if you do have a newer biopsy, it's always best to get a contemporaneous sense of what the levels are looking like, right? But what I was implying was that you don't have to go back to your center and ask the doctor to get a biopsy done now in order to get the results back.
I was just going to make 2 points as well to follow up. So again, just to emphasize, there are just some tests we can do only on the tissue. And of course, one of the points Jessica made and others is that, for example, looking for a histologic transformation, so a change from the original histology of adenocarcinoma to another type like squamous or small cell transformation. Of course, we can really only see that on tissue. So and fortunately, that's not very common, but still it has such important treatment implications that that's what the tissue biopsy is very important for. The second point I wanted to make was around MTAP, because I did talk about it before. We've mentioned it a couple times here. This is a new target that identifies patients who may have vulnerability to a new class of targeted therapies called PRMT5 inhibitors. And I just wanted to mention that, MTAP loss, which Jessica was talking about, actually does tend to be an early or truncal event. So as we were just saying, that is one marker that you could look at the diagnostic biopsy. It tends to not be an acquired event, so that perhaps could be helpful knowing that. But I would also point out for MTAP is we really can't identify MTAP loss through ctDNA, so through a liquid biopsy. So it's not meaningful to look at your liquid biopsy report, not see MTAP reported, because they really can't detect it by liquid biopsy. You really do need the tissue. And just to explain why we think this is important, we already have data on patients with ALK, EGFR, ROS1, who have both their driver, like ALK, for example, as well as MTAP loss. And those patients, many of those patients have gone on to this new class of targeted therapies, PRMT5 inhibitors, just as monotherapy by themselves, and shown sensitivity, so response. And so we're really hoping to gather more data in this space, but it is an important emerging target to be aware of.
Yeah, I'll just also point out, there are a lot of nuances and complexities to all of these tests. And, when we talk about NGS, it's not just one test. So what, one panel covers or a different panel or what's done at one center versus send out to a commercial company to do the testing can vary. And for example, looking at things like MET and HER2 amplification, some centers use FISH, others can make those calls based on the NGS DNA sequencing report. So this is a very complicated topic as to what should be submitted to what test and to what assay, and your oncologist can really sort of help outline that they've done comprehensive evaluation to look for these really important and emerging biomarkers. But it is a little challenging. It's a bit nuanced, so it's really important to talk through it with your team.
Thank you, Mark. So we're finishing. I think Summer's going to give me the hook. Obviously, the questions we ask, these are hard questions. They're complicated, they're complex. You need an expert to help you work through them all. Unless you've got 3 PET positive lesions, which according to Ross makes the decision easy peasy. Thank you. So I want to thank the panel for such a fantastic discussion and sharing with us.